So we're very excited to have you with us, and we're here to talk about diabetes and taking back control. So more about empowering yourself with the knowledge on the latest treatments and the link to heart disease. So my talk is entitled 10 Things Every Diabetic Needs to Know About Heart Health, right? But this is really about cardiovascular health. So don't get just so focused on the heart, because diabetes is a major risk factor for what we call atherosclerosis, right? You guys have heard that word before, but it literally means hardening of the arteries. So it's stiffening of the arteries. And this doesn't discriminate. It literally works on, or it can affect all of the arteries in the body, leading to numerous different problems with multiple different systems. So some of the small arteries in the body, some of the small vasculature can lead to retinopathy or issues with blindness and losing vision in diabetes, nephropathy or the progression of kidney disease in diabetes. And then there's larger vessels or larger arteries that get affected, like those in the heart, but also peripheral artery disease. And what that refers to is just other arteries outside of the heart, meaning the carotid arteries that lead to the brain and can, disease there can predispose for stroke, but also peripheral artery disease, meaning the lower extremities, so the arteries that perfuse the legs. And kind of how people can have angina when they have a blockage in the chest, there's such a thing as angina of the legs as well. And so this is a major problem in the diabetic population, because having blockages in the lower extremities is very prevalent and oftentimes undertreated because people are so focused on the other issues that go along with it. So this is a video describing atherosclerosis. I think the cartoon, it just paints a picture in your mind better than I could explain.
Atherosclerosis is the formation of yellowish plaques of cholesterol and other lipids along the arterial walls. The plaque can build up over time, causing hardening and narrowing of the otherwise smooth artery walls. When this occurs within a coronary artery, it is known as coronary artery disease, CAD. A partial blockage in the lumen of the artery can lead to coronary ischemia or reduced circulatory blood supply. As the plaque accumulates, the buildup may become unstable and rupture. This condition, called thrombosis, results when blood starts to coagulate at the site of the rupture, forming a clot. A blockage in one of the coronary arteries may cause a heart attack.
So I put in only 3 questions, but I think it's fun to take a poll, and we'll just do by a show of hands, okay? So how much more at risk for heart disease is a diabetic patient as compared to the general population? So the answer choices are less risk of heart disease, same risk of heart disease, 2 to 4 times increased risk of heart disease, or 5 to 10 times increased risk of heart disease. Who thinks A? Who thinks B? Who thinks C? D. And then other people think D? Okay. So D has it, but it's actually, I tricked you guys. I made it sound worse. So we'll back up. Now, heart disease is the #1 killer of all men and women, regardless of whether you're a diabetic or not. All men and women in the United States, the #1 killer is heart disease. Diabetics have a 2 to 4-fold increased risk of heart disease. Yeah, that's right. People did say C. It was the second. And that the reason for that is multifactorial, and it's kind of illustrated by this schematic, which you don't need to know any of the words that are on there. But basically what happens is that in patients with diabetes, they have a lot of glucose, a lot of sugar in the bloodstream, and also peripheral resistance to insulin. So your body can't utilize that glucose. And so what that leads to is changes within the inflammatory changes within the endothelium, which is the lining of the blood vessel that we saw in that cartoon. And that's where the plaque starts to form, that yellow stuff that was bad. And so changes to the endothelium then lead to atherogenesis, or plaque formation. And basically what happens in diabetics as compared to the general population is that it means they're at risk for heart disease earlier in life. So especially when you think about young women, we talk about women as presenting about 10 years later with heart disease than men, because you're protected until menopause. But in diabetics, the risk of the risk factor of having diabetes is actually stronger than the protective benefits of being young. So we're seeing heart disease affect younger women. We're seeing worse disease and often multi-vessel disease, and it's because it's a systemic problem, right? It doesn't affect one thing. And I'll show you a picture of this. And then once heart disease is clinically evident, diabetics have a worse prognosis because they have all these other morbid conditions. And this is a picture just to give you another mental snapshot. But if you look at this is an angiogram. So this is where a catheter is going in up the aorta. This is an invasive test, right? So up the aorta and shoots contrast into the coronary arteries here. And what you're seeing on the left is normal arteries, right? So this is the left coronary artery and its branches. And you can see that, in a normal vessel, the blood vessel starts out wider at the top and then tapers as it goes down, and the inside looks pretty smooth, right? This is what we call diabetic disease, where it's lumpy, bumpy, it's diffuse disease. It's not like there's one pinpoint spot that's abnormal that you can easily, put a stent into if there's an issue. But it's more diffuse disease. You wouldn't even know where to get started. And the blood vessels all, as a whole are all much tinier, right? So it's kind of hard to even do anything in those because they're just tinier, sort of skinny, scrawny vessels at the bottom there. And this is typical for diabetic disease. And so your next question should be, OMG, how do I find out if I'm at risk for heart disease, right? Or sorry, for diabetes or pre-diabetes. And what we're talking about in this slide is type 2, or in general, what we're talking about in this presentation is type 2 diabetes and pre-diabetes. Because type 1 diabetes is important, but it's a different mechanism. So it's more your body reacting or attacking your own cells, and it presents in childhood, and those patients need insulin from the get-go. So that's a different entity. But when we talk about the risk of developing diabetes, by and large, the two biggest risks are, one, having a genetic predisposition. So if you have a first-degree family member who has diabetes, you are already at risk for having diabetes or pre-diabetes. And then second is if you are overweight or obese, and we're going to talk about that more on the next slide. The risk increases as you get older, the more inactive you are. And in certain minority subgroups, again, because of a predisposition by genetics, they just more at risk for having diabetes. A note on gestational diabetes. So having, this is not something that women of childbearing age typically think about, their future heart disease risk, but having gestational diabetes during one or all of your pregnancies is increased with is associated with a 7 times increased risk of having diabetes in the future, and is an independent risk factor for having heart disease. But more than half of women who are diagnosed with gestational diabetes never go back after having delivered to get their glucose checked. And it's just because of priorities, right? You've just had a child, you're not really thinking about, am I going to have heart disease 10 years from now? I'm thinking about, how am I going to survive tonight? This is a good schematic looking at the rise in obesity, the obesity epidemic that's taken over this country over the past 20 years alone, and how that has been linked to a direct rise in the rates of diabetes across the country. And so if you look, comparing from 1990s to 2015, there's been a rapid rise in the rates of obesity, and that correlates almost directly. So 80% of new cases of diabetes can be linked to obesity or overweight. And so I would call this a public health crisis. A third of the US population is pre-diabetic. So that is shocking. That means that these people are already at an increased risk of having pre-diabetes. Even patients that I have in clinic who I tell this to don't quite understand the gravity of this, and that there are so many people in the same boat. But 34% of the US population, and then 30 million are living with diabetes. And a shocking 7 million of them or more don't even know it. And so this is a terrifying statistic simply because it could be doing damage to somebody's body for years before they ever even find out it's a problem. And so I would call it, it's something that's linked very closely to weight loss and to obesity, and it's directly related to a ton of comorbid conditions as we age. So there's there's an increased risk of heart attacks, there's an increased risk of strokes, there's an increased risk of heart failure, chronic heart failure, and everything that goes along with that. But also lower extremity diseases, chronic infections, amputations, chronic kidney disease, ending up on dialysis, blindness. I mean, these are a host of problems that if untreated, this is what diabetes can progress to. So the most important thing that anybody can do to prevent diabetes and heart disease is to live a healthy lifestyle. And this is not a cliche, it's actually true. Because the number of cardiac events that can be prevented by a healthy lifestyle is on the order of 90%. And it doesn't mean that you can fight it forever, but early identification of risk factors, a healthy lifestyle, and good treatments are the way that you prevent heart disease. So it's easy to start, right? You just say no to the bad stuff. Say no to smoking, say no to the sugary beverages, just try to cut those out completely. And then just try to substitute in things that are sustainable, that you're not just gonna be able to do for a week or two, but that you can actually implement into your daily life. So substitute in water or seltzer, use natural sources of sugar to flavor, try to de-stress as much as possible and have some sense of mindfulness and feeling centered throughout the course of the day. And have a healthy diet that's based on plant-based sources of protein. So exercise is key. What we say is 150 minutes of moderate intensity exercise, and everybody always says, well, what is moderate intensity? But it can be as simple as brisk walking. Anything that is walking with a purpose, getting your heart rate up, counts as moderate exercise. Bicycling, ballroom dancing, active yoga, swimming. So these are all considered moderate intensity. If you do half an hour a day, most days out of the week, you're good. And it's shocking how many hours Americans spend being sedentary, right? And that's not even including the hours you're sleeping. But more than 7 hours a day doing this, or sitting in front of a desk, or sitting on the couch watching TV to relax after a busy workday, it's just our lives are focused around sitting. And so anything that we can do, any movement at all is beneficial. And it's not just beneficial for heart health, but it reduces blood sugar, it improves the cholesterol profile, it reduces blood pressure, it prevents Alzheimer's, it prevents multiple different forms of cancer, it is like anti-aging, right? It keeps you young, it reduces chronic pain syndromes, and it makes people more productive, improves their sleep patterns, improves their mood and their memory. So there's really nothing negative about exercise in your life. If you could put it into a pill, you would be the richest person on the planet, I promise you. So eating well, and there's a number of different diets. It doesn't have to be one specific diet that diabetics prescribe to, but the Mediterranean diet, which is my personal favorite, the DASH diet, which is the low sodium diet that treats blood pressure or is recommended in high blood pressure, or a vegan and vegetarian diet, have all been shown to improve glycemic control in patients living with diabetes. And the point is to emphasize fiber-rich whole grains, meaning instead of cutting out carbs completely, you want to avoid the refined carbohydrates. And so if you look at the Mediterranean pyramid, which I think is a lot better than the pyramid that we grew up with, because that was all like pasta and potatoes and this at the bottom, like starchy stuff at the bottom. But if you emphasize whole grains and fiber, and then again the focus on plant-based sources of vegetables, fruits, and protein, and using natural fats such as olive oil, avocados, things like that. And if you're going to eat, you want to avoid red meats because that's linked to a lot of bad stuff, right? But if you're gonna have meat, you wanna prioritize lean meats and fish. And your portion of meat on the plate, that's why I included the My Plate. My 4-year-old is obsessed with My Plate, so we talk about this all the time. But the protein should be about a quarter of the plate, or the size of a deck of cards, not bigger. And Courtney, our diabetes educator, is gonna talk a lot more about diet, so I'm not gonna focus a lot more on that. But that's a good topic and a way to empower yourselves. And then as much as you're living a heart-healthy lifestyle, there's no good in denying once you are diagnosed with something, right? So healthy lifestyle habits will help you improve your glycemic control and improve your diabetes management, but sometimes it's not enough and you need to start medication. So what medication is first line for almost all people is metformin. Metformin is cheap. It's old, it's been around for a long time, so it's been studied and it's shown an improvement in cardiovascular outcomes. It doesn't cause low blood sugars, so it's not necessarily dangerous. The biggest side effect is that it can cause some GI upset, that you just have it with some food and you're good to go for the most part. And it also helps with weight loss, so all good stuff. I'm not gonna focus on these other two. I just want you to hear the names, but Dr. Lanier, who's our endocrinologist, is going to talk more about the specific drugs. But in patients with diabetes who also have heart disease or are also at risk for heart disease, there's 2 new classes of medications, both the SGLT2 inhibitors and the GLP-1 receptor antagonists. These are, please don't memorize them, but they're basically medications that have also been shown in numerous studies now to have cardiovascular mortality and heart failure, and even kidney function, to prevent the progression of kidney disease. So there's a lot of evidence around these, and like I said, we're going to talk about them more in the next topic. So question number 2. What medication should virtually every diabetic patient take on a daily basis to prevent heart disease, future heart disease? Is it insulin, aspirin, statins, or omega-3 fatty acids? Everyone says B? You say D? Oh, we have a mix. Okay, so nobody says A. Is that right? A, okay, so insulin, we have aspirin. Who wants aspirin? Who wants statins? And what about omega-3 fatty acids? Yeah? Okay, we have a spattering on all of them. So this is my mic drop. This is the newest guidelines that came out a couple weeks ago, I want to say, at ACC just this year. And it's been in the news, so that's probably why people didn't choose aspirin, right? But aspirin is no longer recommended for primary prevention of heart disease. It's become a very weak indication, actually. You have to prove that somebody is safe to take aspirin. It's no longer the default. So anybody that's less than 40 or over 70, the harm outweighs the benefit. It's no longer recommended. Or if you've had any history of bleeding, ulcer disease, kidney issues, if you're a tiny person and you have some low platelets, anything that it predisposes you to bleeding, or you just don't want to take it, that's perfectly fine. And the recommendation is that it is reasonable for people within the 40 to 70 age group that are at the highest risk for heart disease, meaning a 10-year risk, which you can put into a calculator with your doctor, but a 10-year risk greater than 10%. That is a vast majority of people, even in the diabetic population. Minority of people, even in the diabetic population. And if you are taking aspirin, then only use the baby aspirin, the 81 milligrams of aspirin, to reduce your risk of bleeding. Oh, good. Everybody watches the news. Okay. So blood pressure control, this also was a change that came about, I think, last year or the year before. But basically, blood pressure is now anything above 130 over 80, either or, is considered hypertension. Whereas that used to be in the borderline range before. It used to be 140 over 90, right? So anything over 130 over 80 is considered hypertension now. And if you are a diabetic who has hypertension, the preferred treatments are usually ACE inhibitors or ARBs that can prevent the progression of kidney disease and proteinuria. We talked about the treatment of cholesterol already, or we kind of mentioned this. That was the answer to the question, right? So the answer was statins. If you look at this is also from the primary prevention guidelines. And it's kind of a busy slide, but go over to the green parts, right? So anybody and this is primary prevention. What that means is that this person does not yet, they're diabetic, but they do not have heart disease. So they do not have clinical cardiovascular disease, right? If you are a diabetic between the ages of 40 to 75, you should be on a moderate intensity statin. And then if you are at a higher risk, meaning if you have other conditions that also predispose to heart disease, or you have a high 10-year risk based on the calculator, then you may increase to a high intensity statin. But at the very least, you should be on a moderate intensity statin, every diabetic that's between 40 and 75. And the goal of all of this, of controlling all of the other risk factors, is to prevent or delay atherosclerosis. So this is going back to, I'm glad the video worked, because it's a lot easier to imagine this slide now that you've watched the video. So if you see the progression, plaque starts out as that little, the little plaque that's there, right? And that's not going to cause symptoms, but it's going to put you at increased risk for plaque progression, right? Once it's there, it's not going back. There's no Drano. So there's no way to get it out once it's there. So basically, once the plaque is there, it puts you at an increased risk. Now you should be treated more aggressively, simply because that is there, but it's not clinically evident. You're not going to have symptoms. It's not going to show up on a stress test. Shoot, I gave away the answer to the next question. And then basically it can progress and increase. And then when it reaches this point right here, and I'm sorry I don't have a pointer, but this point right here, where it becomes about 70% of the diameter of the artery, is when it can start to cause where we call it functional, right? So it causes functional ischemia. It starts to cause symptoms, and those symptoms can be very different in diabetics and especially in women, right? We've talked about this in previous seminars, but there sometimes is not chest pain necessarily, but maybe a feeling of shortness of breath or getting tired, losing energy, not being able to walk as far as you used to. So those could be symptoms of an obstructive lesion in one of the coronary arteries. But again, it can correlate to any of the beds, right? So if you have the same symptoms, getting tired after walking a block, whereas you used to be able to walk a mile, that could suggest a problem with the legs, right? So you just think about it as not enough blood flow getting to where it's supposed to go. And that's the point at which a nuclear stress test becomes abnormal, because that's when you're having a problem with the blood supply to the muscle, and that's what's looked at in those. But any of these plaques, even earlier, before they're clinically significant, even the 20-30% blockage that's nowhere near being 70%, right? If that's a vulnerable plaque because you have untreated risk factors or because your body is in an intense set of, sense of stress or something like that, like having the flu or something, right? That can be the plaque that ruptures and causes a heart attack, like we saw in that video. All right, so that's a key point. And again, like I mentioned, women and diabetics and the elderly can all present differently, sometimes without any actual pain or pressure in their chest. So I gave it away. A nuclear stress test will show me if I have any plaque in my arteries. True or false? No, false. False, because it's looking at, so it's not looking at any plaque. It's looking at just plaque that's significant enough to not cause enough blood flow. Right? So if somebody has symptoms of chest pain with exertion, I can do a nuclear stress test and it will tell me if the chest pain on exertion is because when they're at peak stress, one wall of their heart is not getting enough blood flow. And then I know which artery, right? But it doesn't tell you if you have a 20% blockage. That's why you hear stories about people who have, well, my father just had a stress test last week and was given a clean bill of health by a cardiologist, and then they had a massive heart attack afterwards, so that cardiologist must not know what they're doing. It's just that stress tests are not designed to look at that. And so what is? So there are newer modalities, right? You can always do an angiogram the way that I showed you in the initial angiogram pictures, but that's an invasive test. You have to go into a lab, you have to, get poked in your artery. It's a whole thing. So they have calcium scoring, which basically is just going in and out of a CT scanner. There's no IV in your arm. There's nothing else that's needed. And all it does is measure the amount of calcium in your arteries, right? And they can put a score on it, and then they put a percentile risk based on your age and your gender and your ethnicity, and then it gives you an idea of where on a spectrum are you compared to your demographic. And so if you have a calcium score of 0, that's very reassuring. So even if you're a diabetic, if your calcium score is 0, we can try lifestyle modifications for a lot longer, as opposed to if your calcium score is 1200. Right? And so there's sort of there's a gradation that goes along, and it's very nice to have an anatomic assessment of what the arteries look like from the inside, even if the person is asymptomatic, because it helps us to see how aggressive do we have to be. And then taking this a step further, so this is no IV, no, quick in and out. A little bit more radiation associated with a full CT angiogram, but it kind of is the exact same thing as an angiogram in an ideal world, an angiogram that you would do in a cath lab. So it looks inside the arteries. The contrast goes inside the arteries, and you can take a look inside, and you can even do a 3D reconstruction and take a look at how the arteries are running. But knowing what's going on inside the arteries is how you can identify plaque early and then treat people more aggressively. It doesn't mean that you need this test on a yearly basis, but if you're somebody who's a little reluctant or may have side effects to statins or something like that, or you have a high, strong family history, but your diabetes is pretty well controlled, this could be a useful test to be able to put you into a risk bucket. And then the last thing I want to mention is that this is really a team-based effort. I gave you guys a whole lot of information, and I definitely went over time, but I just want to mention that there are a lot of people that need to be involved in the care of somebody living with diabetes. And the captain of the team is always the patient, because you, unfortunately, have to be the ones to coordinate all of this, right? Or you can hire a personal assistant and they'll do it for you, but I don't think that's the reality, right? I think that people need to be engaged in their own health care, and they need to know who they should be seeing and when they should be seeing them. A primary care physician should become your new best friend. You see them every 3 months, because that's how often you want to check your hemoglobin A1C until you're at a stable point and they tell you you can space out the visits. I don't even see my best friend every 3 months, so make sure you like your primary care physician. An ophthalmologist, you need to get your eyes checked so that you can identify retinopathy early. Podiatrist, so you can test for neuropathy and check for ulcers and those sorts of things. A dentist, a nutritionist, or a diabetes educator. And then the list on the right is if applicable. So I don't know, maybe our endocrinologist can speak to it more, but does every diabetic need to have an endocrinologist? Probably not. If you're stable on 1 or 2 medications, your diabetes isn't progressing, you're probably okay under the care of a primary care doctor, right? But if you have long-standing diabetes or any evidence of end organ disease, meaning it's affecting one of your organs, or if you're not, if your disease is progressing to the point where you need more and more oral agents, I think at that point it's reasonable to see an endocrinologist. An OB that focuses on high-risk pregnancies if it's applicable to the demographic, to the age group. A cardiologist, obviously, for all the reasons I've just mentioned. And a vascular specialist, I will say, is kind of a subgroup of the cardiologist, because cardiologists can treat both. What I was talking about in terms of peripheral artery disease and disease in the legs is oftentimes undiagnosed or undertreated, especially in other areas of the country, where to the point where when they present, it's so severe that it leads to amputation. And so the key is to identify this early as well. And then a nephrologist also to look at the kidney disease. And so at least once a year, you need to get your blood pressure checked, your weight and your BMI, your cholesterol, your kidney function. You need to look at the urine to see if there's protein in it. You need to look at the kidney function itself, get a flu shot on top of all the other shots you may need, and a dental exam, a foot exam, and a dilated eye exam. And so I leave you with this picture because it really is tough, but we can do it. Rosie the Riveter may have had it easier than coordinating all of these appointments, but it really is vitally important so that you can stay ahead of it. And that is it. Thank you so much for listening.